Welcome to You, Me, and PD. I'm Vince Kinsler, the Executive Director and President of the Parkinsons Association of Greater Daytona Beach. Today's program is Groundbreaking Technology in DBS Surgery. Pleased to welcome back Neurosurgeon Dr. Sanjeet Grewal. Dr. Grewal is part of the world-class team of brain surgeons in Jacksonville, Florida, which we are so fortunate to have in our neck of the woods. Actually, as far as DBS surgeries go, they have performed literally one of the first in the United States way back in the late 90s. A few thousand DBS surgeries later, we'd have to say they are the experts in DBS surgery. So I'd like you to join me in welcoming our guest today, Dr. Sanjeet Grewal.
Thanks, Vince. That was too kind of an introduction. I'd like to start by thanking the Parkinsons Association for allowing us to come and speak today, and thank Chris and Medtronic for their support. So this is going to be a quick talk. Some of these slides you all have seen before, but I think it's important to put everything in context. And what we're going to do is we're going to start by kind of discussing deep brain stimulation, discussing Parkinson's disease briefly, then going into how we've done things over the last 20 years and how we think things have been improving. And we'll end with a new technology that's come up with Medtronic that I think is really going to be quite helpful in terms of taking care of patients who have very difficult to program Parkinson's disease. I think it's important to state that I have a consulting agreement with Medtronic. It's for epilepsy, not for Parkinson's disease, but nonetheless, since they're a sponsor, I thought it should be disclosed. I'm not getting any reimbursement for today. Like I said, our overview, we're going to start by discussing Parkinson's disease briefly, discuss the treatment options, and then focus on deep brain stimulation. We'll end with some time for questions, but however, if you have a question in between, please don't hesitate to chime in. As everyone knows, Parkinson's disease is affecting a lot of friends, family members, or yourself. It's a progressive disorder, and it has to do specifically with the dopamine-producing cells in the brain. What causes it still remains unknown, and there's a lot of research being done to understand what causes it, and hopefully down the line we can prevent it. It affects approximately 1 million Americans, and 1% of people over the age of 55 will be affected with this diagnosis over their lifetime. As we all know, when we talk about Parkinson's disease, it's broken down into two different types of symptoms, the motor symptoms and the non-motor symptoms. With deep brain stimulation, we really try to target the motor symptoms such as rigidity, tremor, speech problems become really difficult over time, the slowed movements, the feet being stuck to the ground and having shuffled steps, feeling unstable, finding yourself kind of bending over when you're walking. And I think we've done a pretty good job of treating that with deep brain stimulation, and we can talk about that in more detail. However, all these other side effects on the second side, they're just as horrible. So dealing with pain, dealing with insomnia, dealing with cognitive problems and mood problems. And that's an area of research interest with us, and I'm happy to discuss some of the trials we're working on to try to help with that as well. When we discuss treatment with Parkinson's, I think it's important to start with discussing exercise. This is well characterized to not only improve, but hopefully prevent symptoms from worsening. So aerobic exercise is very important. However, as the disease progresses, this becomes more and more difficult to do. When someone gets diagnosed with Parkinson's, the first step in treating this, and one of the ways we really try to diagnose Parkinson's from some of the other mimics of Parkinson's, is seeing if you respond to dopamine. Since the 1930s, we've been doing ablative surgeries. This is either pallidotomy or thalamotomy. These are procedures that are ways to treat Parkinson's, but they're not reversible. And as the disease progresses, they're not things that we can modulate. Something people have probably heard about more recently is focused ultrasound, which is a technique that we have and is helpful in patients who aren't good candidates for general anesthesia or too sick to undergo a larger operation, but it ends up being a non-invasive way of doing essentially an ablative surgery. And then there's deep brain stimulation. The advantages of deep brain stimulation in my mind are, one, we can do it on both sides of the head, meaning we can treat symptoms on your right and your left side. That's something we can't do with pallidotomy and thalamotomy. The other thing is, as the disease progresses, we know it's a neurodegenerative disorder that worsens over time. we can adjust the stimulation and try to continue to keep the symptoms abated for as long as possible. This kind of graph goes into what we think of with Parkinson's. So initially, when you get diagnosed, people respond to very low doses of dopamine and do very well. As the disease progresses, you have to take the medication more and more often. But not only that, you start having side effects, what we call dyskinesias, because you're taking it so often that you're getting the side effects of the medication itself. However, if you don't get it, you're not getting any of the benefits and you're frozen and have the off time. So when we talk about deep brain stimulation, these are the things that we're very good at helping. Tremor, rigidity, trying to reduce some of those medications and the side effects of those medications. And the majority of patients who have this surgery would say they would do it again because it really improves their quality of life. So when we talked about initial deep brain stimulation, as it started in the 1990s, it was what we call an open loop stimulation. When we put a stimulator in, you had 4 contacts that you could program around. It's a surgery that was done awake, and we had to figure out exactly where to put the electrodes. So we would put tiny little microelectrodes in first and listen to the brain cells to make sure we were in the right place. This picture on the right here is from an atlas. This is an atlas that was basically created by looking at cadaver specimens of 5 patients in the 1950s. And what we found was that, if a patient had, and this goes back to the thalamotomies and the pallidotomies, if a patient had a very small lesion in that location, their Parkinson's got better. So what we did with deep brain stimulation when we started was, well, we know that pallidotomies work in that location. So let's try to put a stimulator in and see, instead of causing a lesion there, if we can modulate that area. So when we looked at hundreds of people over time, we started to make these atlases a little bit better, a little bit more patient specific. But basically all we were trying to do was fit your brain to these 5 other patients' brains and try to find the right spot to put the electrode. When we did that, we had to do the surgery awake because we'd want to make sure that the electrode was in the right place, and then we would test it to make sure that when we left the operating room, we were happy with where the electrode was. This picture on the left is this microelectrode. It's 1 to 2 millimeters. It's a very small electrode that goes in. And this picture on the right shows exactly what we're seeing. So on the computer, when we put these into the brain, we're seeing that cells, these neurons in different parts of the brain, respond differently and they fire at a different rate. And we knew we were in the right place when we got this pattern. And not only could we see it, you can hear the electrons firing. And when we got a very distinctive sound, we knew we were in the right place to either do a pallidotomy or to do deep brain stimulation. And this is just a typical electrode to compare the microelectrodes to. It's a little bit larger, and we need that to be able to stimulate appropriately. This picture on the right is a picture from those atlases of the different subsegments of the brain where we want to get the electrodes in. We've come a long way in the last 30 years. This is what your MRIs look like now. And MRIs have gotten so good that we can actually see these areas on your MRI. So in a lot of patients, we can do the surgery asleep in the MRI suite. And the advantage of that is you don't have to stop your medications for surgery. You don't have to be awake. And we've shown reliably that we can put the electrode in the right spot based on the imaging alone to get you the benefit effects of deep brain stimulation without some of the consternation of having an awake surgery and having to be tested while you're awake. There's lots of different ways to implant electrodes. This on the left is what we call a frame-based. This is the traditional way of doing it. We still do plenty of our awake surgeries this way. This frame right here is a new fiberglass frame. It's quite light. We were one of the first places in the country to use this frame. It's only been out for about a year. The system right here is a system from Medtronic, and it's a way where we don't have to affix this frame to your head. It's a smaller frame we can put right where we're going to do the surgery. We can use robots to guide us. So all this would be on the side of the bed. This is where the head would be, and the robot guides us to exactly where we want to be. And then when we talk about doing it asleep in the MRI suite, what we can do is similar to this frame, but this is a frame that works in the MRI suite. So it has no metal parts, no magnetic parts. And we can ensure with you being asleep that we put the electrode in exactly where we want it. And we can actually get an MRI with the electrode in place while you're asleep to make sure that it's right where we want. All these are different ways, and every center does things different ways depending on where you go. We have the option of doing any of these techniques for you. One of the recent advantages of deep brain stimulation came with what we call the specialized stimulation technique. This you might have seen earlier, but is initially came out with a company called Abbott. Then Boston Scientific came out with their version, and Medtronic should be coming out with their version shortly. But what this allows, and if this video plays, is it actually segments the electrodes so we can be more specific in where we do the stimulation. We can go up and down, but we can also directionally steer the electrode towards one side or the other so we can maximize the benefits and minimize the side effects. And then once the electrode's in place, the question is, well, how do we decide what settings to go on? All right. This is a timeline of kind of where we started and where we're at right now. So initially we understood the brain circuits. That was in 1986. And, there was actually a Nobel Prize won for identifying these brain circuits and how they work. Then in France in 1987, Dr. Benabit started doing the stimulation. And at the same time, we started saying, well, okay, we understand these networks. Can we image these networks? And that's what we started doing. And if on the top, what you see is the advantages in the imaging, and the bottom, you can see how those are applied to the surgeries. So we started looking at connectivity. So we wanted to look at how your brain functions and how different areas interact with each other. And that was the idea of the brain connectome, that it's not just one place, but it's how these places interact with each other. Based on that, we then developed structural connectivity, where we were like, okay, well, now we know these areas interact with each other, but can we identify the pathways these use to interact with each other, what we call fiber tracking? After we did that, and we had done enough patients with that, we developed what we call a normative atlas. So this was kind of like those atlases based off the cadaver brains, but off thousands of patients' MRIs to say, okay, well, this is a little bit more of the functional connectivity rather than just the anatomic connectivity. Most recently, this is a paper by myself and my partners where we were actually able to individualize your functional connectivity. So our patients get an MRI where we actually look at how your brain regions are connected to each other before surgery. And I'll show you in this next slide how this works in terms of programming. So once your electrode's in place, this is your electrode that goes into your brain, you get an MRI. And then we look at all the fiber tracts in your brain and we see how they're connected specific to you. Then we do a functional test and say, okay, well, if we were to stimulate a certain part of the brain based on how these regions are connected, how are we going to activate the areas of interest that we know? This develops an atlas that's specific to your brain. And what we've done is then after surgery, we can calculate kind of what we think is the ideal area to stimulate. So that when we start programming you, we do it based on this imaging and this predictive model of what's going to be the best. And then there's some fine tuning involved as always, but it's really made the programming go from these, multiple visits, 2-hour sessions to most of our patients get, a 45-minute visit for a fine tune-up, and they usually need maybe 1, maybe 2 to get to where they are until their disease progresses, and eventually they need some more fine tuning. This is another example of doing the same thing. Once you have the electrode in place, this is your personal atlas. Once we figure out where we're going to stimulate, and this tells us, okay, if we stimulate on this electrode, we're going to activate this part of the brain. And we know based on many patients that activating certain parts of the brain leads to good benefits and fewer side effects. What Medtronic's come out recently, and what we're quite excited about, is what we call brain sensing. And I'm going to go into this. There's some science involved in this, but I'm going to try to bring it to a point where we talk about how it's important for you as a patient, okay? I think the long and short of it is brain sensing is a way that's going to allow us to program based specifically on your brain signals. There's two different types of signals we get from the brain. The top is what we've used with those microelectrodes, where we look at specific neurons and we say, okay, we hear this neuron firing, so we know that this neuron firing tells us we're in the right place. The bottom is what we call a local field potential. Now, this is a population of neurons around the electrode. And what we can tell is that, okay, if these populations of neurons are firing in a specific way or giving us a certain signal, you're more or less likely to either have good benefit or side effects. Those frequencies we talk about are basically broken down into these 5 frequencies here. Delta waves are slow, calm waves. Theta waves get a little bit faster. Alpha get really, really fast. Beta waves, and we'll talk about this a little bit later, are very important in terms of brain sensing, as well as gamma waves. These are typically abnormal signals that tell us, okay, we need to adjust the stimulation one way or another to get the benefit that we would desire. So just remember that the beta waves and the gamma waves are the fast frequency waves that we see in a signal. And they're usually a sign of something not working the way it normally does. Typically, when your brain's resting and it's normal, it's usually got an alpha or a theta wave. And this is what Medtronic showed, that beta waves, these waves that we get from the electrode, specifically with their new battery, is a stop signal. So patients who have rigidity, patients who have freezing, aren't able to move quite as well. We see that if we look at the brain waves, we have a lot of beta activity. That tells us that we need to program and change our programming to try to eliminate that, which correlates with your effects down the road in terms of getting you moving more fluidly, stopping the freezing. However, if we see gamma waves are a go signal. So that's when patients have dyskinesias. So if we start to see gamma waves, that tells us, okay, we're getting to a point where you're likely going to have side effects from the stimulation, and we need to get out of the gamma waves. This holds true not only for deep brain stimulation, but this holds true for medication. So patients that are just on medication and aren't being stimulated, that beta signal is a stop signal, a rigidity signal, and that gamma signal is a dyskinesia signal. So gamma means you're getting too much of your Cinemet, your beta means you're not getting quite enough. And when we optimize your medications, these signals go away as well. So what's the goal with all of this? Right now, I briefly mentioned what was open loop deep brain stimulation. We put an electrode in, we see you in the clinic, we see how you're doing, and we change your monitoring. The goal for all of us is a closed loop deep brain stimulation. So we put the electrode in, we program you based on the imaging that I showed you, based on the brain waves that we see, and then the battery gets feedback. Right now, that feedback, when you come to the clinic, is seen by me or seen by your neurologist, and we adjust, and then that tries to optimize your stimulation. And that's eons beyond where we were even 5 years ago. And it's really allowed us to become more precise with our stimulation. But what our goal is over time to learn, okay, well, what stimulation parameters get rid of beta waves? What stimulation parameters get rid of these gamma waves? And once we've developed that with artificial intelligence, the goal is to have these batteries work in a way that they can adaptively do this. So when I see you in clinic, you're in a certain state in terms of your meds, you're in a certain state in terms of your stress, it's a specific time in the day. That fluctuates, and these waves fluctuate throughout the day. So there's times where in the clinic you're programmed great, then you go home and you're like, oh, this isn't quite as good as it was in the clinic. A few hours later, it's back to feeling really good. And that's because your body's changing throughout the day and throughout time. What's exciting about the Percept battery is it already has that chip placed in. So once we get enough information, the hope is that we'll be able to activate this feature and really allow dynamic act. So we would put in basically a program into the device to say, well, when this beta wave appears, you need to change the stimulation this way because you as our patient are starting to become more rigid and we need more stimulation. Or when this gamma wave appears, that means, oh, look, the patient's probably developing more dyskinesias. and we need to slow down the stimulation or adjust it in a way that gets rid of the dyskinesias. Our goal is to get you to a point where you see us once you're programmed, we set up this artificial intelligence onto the program that constantly adapts to your Parkinson's and constantly adjusts so that we can maximize the benefits of deep brain stimulation. And that's what's really exciting for us and what we see in terms of the future, in terms of deep brain stimulation, when we talk about closed loop deep brain stimulation. I think this Percept battery is really quite exciting from that standpoint. I think it gives us some advantages in being able to do that in the near future. All right, guys, I'll take any questions at this time.
Dr. Grewal, thank you. I've got a question. This is based on what you had just explained there, just so I have a clearer understanding of how the Percept may enhance, taking DBS to the next level of, continuous treatment. Again, I just want to have a clear understanding of it. If somebody, which everybody will eventually, as you'd mentioned earlier, someone that has DBS surgery, over time, they evolve again, they progress. And so is it at that point, someone that has already had DBS surgery, and now they're starting to express symptoms coming back into their life that previously weren't there or are becoming exacerbated? To understand how the Percept may work, then is someone like yourself or a neurologist looks at that and says, okay, you're experiencing dyskinesias, or you're experiencing bradykinesia, and whatever it is that's evolving, then you actually have to program the Percept, and then it starts to pick up on that by itself and then delivers whatever the brain needs from that point forward to help offset that new symptom. Is that how that works?
Exactly. So where we are right now is that it's not dynamic. It can't do it on its own yet. It has the technology once we have enough information to hopefully be able to do that. So it still requires you to come to us and have those programming adjustments. But what the advantage here is you can say, hey, doc, at 3 o'clock every day, I start to notice dyskinesias. Or at 5 o'clock, I start to notice freezing. I can go back into the battery and look at exactly what your brain waves looked like at 3 o'clock or at 5 o'clock and look at those brain waves and say, okay, yeah, you're right. At that time, you were having this rigidity, and we could see that electrophysiologically. So what we can do is we can say, okay, well, let's put in 2 different programs that you can switch between. So that around 3 o'clock every day is when you start having this rigidity. So you switch to this program that's optimized to try to help with your rigidity. Okay, well, at 5 or 6 o'clock, you notice you have your dyskinesias. Well, there's a different program that's going to work better for your dyskinesias, and we'll program that in. So when you're having your dyskinesias, you switch into this program. And the patient programmer allows you to do that at home by yourself. The hope with closed loop deep brain stimulation is that eventually it'll just do that on its own. It'll notice that you're having the dyskinesias and adjust to it. So you won't have to even think about it. But where we're at right now is that we can look at that over time and say, yeah, it's very consistent that you're having dyskinesias or rigidity or whatever symptoms day to day. And you can have different programs that adjust to it.
Wow.
So it's not only long-term as the disease progresses, but also the variability in the day-to-day. We can fine-tune programs and allow you to switch between them.
We've been hearing a lot in the past few years about personalized medicine. I've never really considered the fact that an implemented device could be viewed that way. I always viewed it as some sort of a cocktail of different pills, if you will. So this is really on that forefront, I think. I do have another question here, one from our chat box. It's a good question too, because you explained the 5, I think it was, different brain waves that we have going on. This individual is asking, can different parts of your brain have different waves? And I think what they may mean there is at any given time. I mean, if you're experiencing gamma where things are really active, is that just one part of your brain, or could your other part of your brain have a theta wave going on?
Absolutely. So in fact, you can have multiple waves going on at the same time. So what this, let me see if I can go back here. So what this local field potential is, so each neuron right? Each brain cell can be firing at a different wave. And what this local field potential does is it aggregates those waves together to give us this signal. And then through some advanced mathematics, we can go and break down those waves to see which waves are predominant, right? So it's not that each of your brain cells or each of the parts of your brain are having the same frequency. Now, parts that are connected in a network usually fire at the same frequency or the same wave, but different networks could be working at different wavelengths at the same time. And that's when we talk about a dominant wave, which is the predominant thing that's kind of taking control and driving how your brain's working. But there's other non-dominant waves going on at the same time. And the idea is to try to switch you from one network to another or one state to another.
Huh. Wow. It just shows how dynamic our brain really is. Is there any clinical studies when we talk in terms of a couple of the different advancements in DBS that have taken place over the years, and of recent, I think going back, the first ones to come out with a directional of some sort was Abbott. I think it was called St. Jude.
Yeah, I think it was St. Jude's at the time. Yeah.
But is there, with regard to that, maybe turning on and turning off, or directing, or even with Percept, is there any clinical studies that show that DBS is better than constant stimulation as far as on-off DBS, as far as constant stimulation?
There are, and I think maybe Chris can direct you to some. Medtronic has a list of, I think it's 10 or 12 large studies that have shown this over the past few years.
And Chris, before you go there, can I just add too? I mean, is with regard to Percept, and it sounds like amazing technology, and I think it can go a long way. I suspect from where it currently even is, even though it's still very new. But is there a big advantage of Percept over the directional leads?
Well, and the idea is that with Percept, within probably the next year or so, we will have directional capability, if I'm not mistaken in that, Chris. Is that correct?
Yes, sir, that's correct.
So did you want to cite any clinical studies, Chris, regarding whether constant stimulation is?
Yeah, so it's interesting, Vince. We've been studying this for the past 10 years. Dr. Grewal is involved in some of that, as you can see by some of his slides. And we've got some data that suggests that these beta waves and these gamma waves do correlate with Parkinson's symptoms. And by identifying those with the preset battery, we can make those adjustments and hopefully eliminate some of those symptoms. So yeah, this has been heavily studied for the last 10 years, and we're going to continue to gather that data so that we can move forward towards this closed loop situation.
It would seem, Chris, then that Dr. Grewal had mentioned, I guess, the prospect, and you and I have talked too, of a directional lead being put out by Medtronic. That would seem like a natural evolvement. I mean, to really enhance how Percept would work. So how close is Medtronic to the directional?
Yeah, so that's definitely on our list. We're probably about 12 months away still. I don't have the exact time frame for that, but definitely a priority, and it's going to tie right into the Percept. The other thing about that Percept battery is it's completely upgradable. So as this technology changes and we get further in indications for use, we can update that battery that's directly in your chest through software. So this is a battery that we see is going to last a long time. It's thinner, it's smaller, and the battery life is going to last longer than our traditional Activa PC. And again, it's going to be upgradable. So as we get those those indications, we can move forward with them.
Is quick question along that line? It got me thinking. There is Percept. Is it going to only be usable proprietarily with Medtronic leads, or can it go across the board with other manufacturer leads?
So that's a good question, Vince. I don't believe so. I don't think it's going to be indicated for mixed systems, if you will, because none of that's been tested. If you get a new preset battery, Medtronic extensions and leads, this device would be a 3T MRI compatible device. And to have that type of indication for the 3T MRI, you wouldn't be able to have a mixed system.
Yeah, that kind of makes sense. Let me see. I think I might have another question here. Question is from one of our attendees, Emily Jones. How long does it take between deciding you want DBS and having the surgery? Probably Dr. Grewal.
Yeah, absolutely. So for us, what ends up happening is you come and see my partner, Ryan Weedy, who's a neurologist, one of the original people who did deep brain stimulation. And once you guys agree that that's what you want to do, typically around 2 to 3 months is our wait time right now.
I would imagine that the person would have to qualify too. So there's a process there. I don't believe
exactly.
a candidate.
And that usually occurs over those 2 to 3 months. So you have the initial meeting with our neurologist, and that's where we kind of determine whether we think you're a good candidate or not. We have a weekly meeting where we discuss all our patients together with our neuropsychologist, our neurologist, and myself. And then we give you a call once we think that you're qualified, but the whole process takes about 2 to 3 months.
Going back, Chris, to what we were just discussing a little bit as far as adaptive use of different technologies, it just seems what's kind of heartbreaking is that I don't know how many people currently in the United States that are walking around with DBS leads in their head. I would imagine tens of thousands, and would be so good to have something that worked well for them, where they could unplug and then plug something else in that would work better for them.
Well, actually, Vince, if you had a Medtronic lead placed 10 years ago and you put this new Percept battery in, you would still be able to interpret brain signals from those old leads. So you don't have to have a new lead for that. So if you have a replacement situation where you have an older battery, you get the new one, we're going to be able to utilize some of those brain sensing advantages.
Well, that's definitely good news to hear that, because obviously Medtronic's been around the longest with regards to these implemented device brain stimulation surgery. I think probably one of the first, or if not the first. We got another question here. I know everyone is different, but what typically happens when someone stops medication before the surgery? And they're also thanking for the excellent presentation.
So what we basically ask you to do is stop medication at midnight the night before surgery. And that's so that when we do the surgery, we have you kind of at your worst, because we want to optimize the placement of the electrode and make sure we're getting you your best benefit and your best chance at reducing the medications. What typically happens is if you think of your off state of medication, so kind of when the side effects of the medication stop, that's what you would experience temporarily. So just think about it as if you skipped a dose, how you would feel. That's how you would feel that morning.
I've got a question along those lines. You're talking about the full sleep DBS sort of lends itself into that. People start to feel miserable, but if they can be anesthetized during the process, that sort of takes that away. Not just that component, but certainly the anxiety of being awake, having this kind of surgery. The question I have is why, maybe it's a cost thing or a reimbursement thing, but what about bilateral placement? As soon as you're going in there for surgery, why just go one side? Why not place two?
Yeah, absolutely. So we've published our data on this. Dr. Foote and Oken at UF have published their data on this as well. And there's a large, I think it was like 10 different centers, academic centers published their data. What we've found is that the brain doesn't like both sides being implanted at the same time. So in terms of you recovering from surgery, you feeling back to yourself, it takes longer. And also the second side always is not quite as good as if we had done it 3 months apart. So what happens at the time of surgery is the brain moves just a couple of millimeters. But when we're talking about something as precise as deep brain stimulation, if you're off by a couple of millimeters, you might as well be a football field away. So, while it's convenient, and it's convenient for us, we could do a lot more patients if we could do bilateral at the same time. We think in terms of the patient's recovery and overall optimal placement of electrodes, it's better to do it separate and allow the brain to recover in between.
Makes sense. Going back to the placement component and talking about the imaging today being so good, and relegating that to the maybe the full asleep surgery, is it really as good? I mean, is there any clinical determination? I don't even know how you'd come up with a basis for saying, yeah, it's equally as good, unless it's just based on pure numbers of surgeries.
So it's actually, there's been hundreds of patients published comparing awake versus a sleep study in terms of, especially in Parkinson's, we look at the UPDRS. It's a motor score of the Unified Parkinson's Disease Rating Scale. And we've shown that we can get equally good results in terms of improvement in those scores doing awake and asleep. So for me in a Parkinson's patients, the only reason to do an awake surgery at this time is if they have a really bad tremor. And that's because at our center, what we'll do is we'll actually put a second lead into the part of the brain that controls tremor. So you get 2 leads through the same hole, same surgery, same incision, but that optimizes your tremor control as well as your Parkinson's control.
Huh. So it just hooks up to the same pulse generator. So where bilateral, would it not have its own generator?
Yep. So bilaterally, you'd have two generators.
Very interesting. I believe that does it. I really appreciate Dr. Grewal with the great program. Chris being there for support. It's good having you both. Get real quick. Speech. Is there any help along the lines of speech with regards to DBS? I know, because we're knowing DBS, they're applying it to a lot of different areas now. I know epilepsy is huge.
It's a target that we're interested in, but everything's experimental right now. So I can't really discuss it with the group at large, but it's something we're working towards.
Excellent. So with that, I'd like to thank again, Dr. Grewal for coming back to visit with us. And I hope you'll come again. And same to you, Chris. Thank you for joining us today.
Thank you everyone for the invite.
Thank you.